Hello friends, myself Dr. Anurag Tiwari, and today I will demonstrate you the surgical technique of biceps tendon repair. So we have the patient, young male, who injured his left elbow while lifting heavy weight at the gym. He developed the injury to the biceps tendon. There was avulsion from the biceps tuberosity of the radius. So the patient lies supine, the forearm is supinated. We use the transverse incision about 1 to 2 centimeter distal to the elbow flexion crease. The incision should be 3 to 4 centimeter in length depending on patient to patient, and we begin the incision by incising the skin. The surgery is being done under tourniquet in order to prevent the blood loss. So here be careful you do not injure any cutaneous nerves or the major vessels. They are the brachial artery, radial or ulnar artery, or the median nerve. They are the crucial structures which are present at this site. The small bleeding vessels needs to be cauterized in order to obtain adequate hemostasis, to prevent post-operative hematoma and to prevent post-operative pain. Once the skin is incised, you have to do the superficial dissection. The superficial layer of fat needs to be dissected using the scissor and the forceps. Be careful you use the blunt dissection. Do not use knife or cautery underneath the skin, otherwise you will injure some nerves or major vessels. So just by doing this dissection, you will be able to separate the superficial layer of the fat. After dissecting through this layer, you will be able to see the white color facial layer just beneath this layer. This layer is quite thin and you will be able to dissect it with the help of scissor. Once this facial layer is incised, the next step is to identify the tendon end which lies proximally. Usually in chronic cases, it is quite difficult to identify or retrieve the tendon end because it gets retracted proximally because of the muscle pull. However, in acute cases, like this case was almost 7 days old, we were able to identify and retrieve the tendon end through this wound. Once you retrieve the tendon end, so this is the proximal end of the tendon, the biceps tendon. You take control by attaching the Ellis forceps or Cocker forceps, but be careful. Don't use these forceps in the middle of the tendon. You have to insert it at the end so that you don't crush the tendon mid substance and you don't injure the tendon. The next step is to take hold of this tendon and you attach the suture, either fiber wire or vicryl or nylon or any suture you may use. The purpose of this suture is to take control over this tendon, so that once you take control over this tendon with the help of this suture, you will be able to give traction to the tendon. You will be able to retract this tendon out of the surgical wound and you will have the control over this tendon. So this is just a temporary suturing over this tendon in order to gain control over this tendon. So we have used a vicryl suture for this purpose. Once you attach this suture to the tendon, you will now release the Ellis forceps. The another advantage of using this suture is you will protect the tendon by not using the Ellis forceps. We will prepare the tendon later on. Once the tendon is identified, The next step is to identify the insertion point over the radius, proximal end of the radius bone. The tendon inserts onto a tuberosity that is known as the bicipital tuberosity or biceps tuberosity that is present in the proximal end of the radius, just beneath the neck of the radius. So that is again very important. You identify the correct insertion point in order to gain the full flexion and extension of the elbow as well as the supination and pronation of the forearm. As you know, the biceps is a good flexor of the elbow as well as a good supinator. Again, very careful, you have to use the blunt dissection in order to retract the soft tissues, the deep fascia and the joining the adjacent muscles and other tissues to gain access to the bone. The finger dissection is quite safe. You will use the blunt dissection using your index finger in order to clear the debris, in order to clear the other tissues, and you directly gain access to the bone. So you are now able to palpate the bone. The next step is to identify the correct insertion point on this bone, that is the radius. So you see, I have used artery forceps to tie this suture to the green sheet so that now the tendon, the proximal end of the tendon is not interfering in the surgical dissection. This is again the advantage of the vicryl suture to get control over the tendon. I have used the artery forceps and I will use it as a marker over the bone so that I can identify the correct insertion point under the C-arm guidance. So this is the C-arm. I am taking the images. Sorry, I don't have the C-arm images to show you in this video. But while seeing this, the artery forceps was quite proximal in the radius. So we will do the dissection quite distally. So we have to move 1 to 2 centimeter distally to this bony site. I will use the periosteal elevator or the curved osteotome you may use. Flex the elbow so that you will gain access to the distal portion on the radius. Once you identify the bone, the correct site, you will feel that the site where the tendon gets attached, because of the avulsion, it will look rough as well as it will be feel somewhat rough. Now this is the green colored structure is the suture anchor we are using to fix the tendon into the bone with using this suture anchor. Again, we will check the insertion point using this suture anchor under C-arm guidance. There are various methods of fixation of this tendon to the bone. One of them is the suture anchor, that is the most advanced technique. The other methods are you can use the bone staple. You may use the pull through technique by using endo button or suture disc on the opposite cortex of the bone, or you may use interference screw like we use in ACL PCL ligament reconstruction of the knee. So these suture anchors have the screw like structure at the end, and on that screw multiple threads or multiple sutures are being fixed. Now to insert the suture anchor, we will first make a pilot hole using the drill bit. So just retract the tissues, slightly flex the elbow so that the soft tissues over this bone gets relaxed. And once you retract, you will be able to see the bone. I will use the drill sleeve in order to protect the soft tissues, nerves and vessels. And using the drill, the battery operated drill, I will make a pilot hole. Again, it is a very good practice. You check that whether you are at the correct insertion site under C-arm guidance, and the hole should be perpendicular to the bone. exactly at the 90 degree in order to gain the good strength or the good purchase in the bone. Once you drill the pilot hole, you will identify this hole and you will insert the suture anchor. So you retract the soft tissues and you identify the hole you made in the bone at the bed, and by just gently rotating by the screwing mechanism, you will insert the suture anchor inside the bone. Usually single cortex is sufficient. However, if you are able to get the purchase in the bicortical purchase, it's beneficial. It will provide a good purchase in the bone. As this patient is a muscular individual, I have preferred to use the suture anchor bicortical purchase. So once you insert this suture anchor, just remove the handle and you will have multiple threads coming out from the screw. Now this screw-like material is inside the bone, you can see, and this provides a good strength or the purchase inside the bone. A good reliable test is to just hold the threads and you just pull them. The weight of the limb should be, the patient should be you should be able to flex the elbow. So that means it is having good purchase in the bone, otherwise the screw will come out. So there are 4 threads. This is a double loaded suture anchor. There are 4 threads of fiber wire. The fiber wire is a material which is having one of the most strongest material in orthopedics. So there are 4 threads. Now we will tie these threads to this tendon in order to fix this tendon to the bone, and there will be the healing of the tendon to the bone. So I will be using the needle and I will pass this thread through the eye of this needle. This is a common needle which we use, that is a sewing needle, and it is autoclaved and sharp. The next step is to debride the end of the tendon. The tendon, from where it was avulsed, the ends were frayed and quite rough. So in order to have a good healing with the bone, it is essential that you debride this end so that it becomes neat and clean and it gives a good hold in the bone. The next step is to tie these fiber wire, the threads of the suture anchor, through this tendon, through this proximal end of the tendon. So there are multiple methods you can use in order to suture this thread into this tendon. One of them is the Krakow stitch or the whip stitch, or in a random fashion you may use, so that it provides a good purchase of this fiber wire inside the tendon. The multiple stitches should be taken so that there is a good hold of this wire through this tendon. So from one end we move proximally, and about 1 to 2 centimeter of the area we covered with. Then we move on to the opposite side, and in the same way we will take stitches from the opposite end. So like you see, this provides us circumferentially a good fixation of the fiber wire through this tendon. Again, multiple suture, multiple stitches, 3 to 4 times you need to take. And you pass the suture through the end of the bone. This will help in healing of the end to bone the radius. Hold both the ends of this fiber wire and you will give enough traction to the tendon. Again, the same step is being repeated with the other wire. Remember, we have the 4 threads, so there are 2 fiber wires. The 2 ends are attached to the suture anchor and 4 strands are coming out from the suture anchor. So in the same way, in the same fashion, we will use this suture again to stitch the tendon. Now this provides a backup or another layer of fixation so that this doesn't get easily ruptured or this doesn't cause any failure of the fixation. So in the same way, you have to take the Krakow type of stitch or the whip stitch or any of the preferred method you may use. From one end we start and again we move to the opposite side, and after taking multiple stitches we take this suture out from the end of the tendon. So this is the last stitch. So we will take the needle through the end of the tendon so that it gives end to side healing from tendon to the bone. So we have the 2 strands of these threads coming out from the end of the tendon and the 2 strands are coming out from the sutured end. Now we cut the vicryl which we have used to take control over the tendon. Now there is no use of the vicryl suture. Again you pull all the sutures through the tendon so that it gives a good fixation and there is no lag or no laxity in the fiber wire. Now you have to identify all the 4 threads so that there is no entanglement between the threads, there is no knot between the threads, otherwise the fixation will not be good enough. You identify the suture anchor. Again, very important step that when you tie the sutures, you do not cause any injury to the soft tissues and there should be no soft tissues between the knots. Otherwise it will cause injury to the soft tissue, and secondly it may cause the slippage of the knot if there is a soft tissue between the knots. So I am just differentiating the threads, just identifying the ends so that there is no entanglement and there is no soft tissue between the threads. So you have now the 4 threads, 2 threads coming from the suture anchor going to the tendon and coming out, and the 2 strands are directly coming from the suture anchor side. You identify, you differentiate all the 4 strands, and now the next step is to tie the knots in these suture strands. When you pull one of the end which is going through the suture anchor, the tendon will pull or the tendon will be pushed towards the bone and it will cause compression at the bone site. So again, very important step, you need to check any soft tissue not getting entangled between the tendon and the bone, and there should be a direct contact of the tendon with the bone. To check the stability, to check the strength of the fiber wire, again you can check it by pulling the strands of the threads. When you pull these threads, the tendon is coming in contact with the bone, and when you give traction to these strands of the threads, there should be elbow flexion. That is the action of the biceps. That is the main purpose of this surgery. We want to provide the function. The flexion is weak, so when this secure fixation is gained, the patient will be able to achieve full flexion at the elbow. So this is a reliable test that there is a good fixation and good strength of the fiber wire. So now we will tie the knots in these threads one by one. And there should be full flexion and full extension possible. There is no block, there is no extension or flexion restriction. So one by one we will identify the threads and we will tie them. That finishes our fixation. So these are the two strands. We identify it with the artery forceps and we pull. With one assistant pulling on this strand, just keep the flexion, pull as much as the flexion should be around 10 to 20 degree. In this position you will identify the thread and you will tie the knot. The simple surgical knot is being tied, and this thread should be in tension so that the knot doesn't slip and it provides a good fixation and a secure fixation. You need to tie multiple knots, at least 4 to 5 knots should be there. So these two threads are tied now. You check again that the tendon is holding its place in the bone. And now the second threads or the second strand should be fixed. That is as a backup. The patient is a gym lover. He needs to go back to the workout. He needs the biceps strength should be as good as possible as it was in the pre-injury status. So we are here to achieve a good fixation, a secure fixation, so that the bicep doesn't get weak. So now the second strand of fixation is being tied. So this knot is being tied. Again you need to check that whether any soft tissue is not being entangled between the knots. Again the same way you have to give a multiple knots in this thread. About 4 to 5 knots are sufficient. And check whether full flexion and extension is possible. The knots are not impinging onto the soft tissues, and they are quite tight enough to provide a secure fixation. Now these 4 strands, we will attach them in a crisscross pattern alternatively, so that this gives again a good and secure fixation. So we have the 4 strands or the 4 sutures. So we will tie them one by one in a crisscross pattern. So these 2 are tied once knot, then the diagonally opposite threads are being tied, then again in a diagonal fashion these 4 strands are being tied to provide a additional fixation. Now the next step is to see under vision the knot, the tendon and the bone and the range of motion, the range of movement of the elbow. So if it is a good fixation, the knot should be visible, the fixation should be strong enough, the full flexion and extension should be there. I will ask the photographer to just zoom in so that you can see the knot and the secure fixation, the tendon where it is attached to the bone. Just see here, I will retract the soft tissues. By zooming in, you will be able to see the knot. So this is the knot visible, and by rotating the forearm, you will be able to see the tendon. It's visible. Just see, while rotating the forearm, the tendon is moving. That means it is adequately fixed to the bone. The remaining threads will be cut with the help of a knife or the scissor. So this completes the fixation. The next step is to have adequate irrigation or wash in the wound to prevent the surgical site infection. So a good wash or irrigation is advisable. Later on, the next step is the closure. So we will close the subcutaneous layer using the absorbable suture. I prefer the vicryl suture, the 2-0 or 1-0, depending on the patient's skin or the tissues you may use. And the knot should not impinge on the skin, and it should not cause any irritation to the patient. So 3 knots will be sufficient, I guess. For the skin, you may use the nylon or proline or any other absorbable, non-absorbable suture, or even you may use the skin stapler in order to suture the or fix the skin. So this is again an important step. After every surgery, you need to tighten the skin, you need to close the wound cosmetically as well as functionally. So this is how the surgery is being performed. And after this closure, you will do the dressing, simple sterile dressing, and a slab is being applied in order to protect the fixation. The slab is removed after about 4 to 6 weeks, and gradually the range of motion exercises are being started. So this is the patient at 3 months, the full flexion and extension, and the supination and mildly restricted pronation is there, but otherwise a good range of motion. The incision heals well. So this completes the technique. Thank you so much.